A young, curious child plays in the backyard, unaware of the danger ahead. In an instant, a wire pierces their left eye. Decades later, now elderly, they seek a solution through surgery. A cornea, fragile and altered, its central thinning, glaucoma, and extreme irregularity pose a significant challenge for biometric calculation. The surgery unfolded as planned, progressing smoothly and without complications for most of the procedure. Just as we were about to seal the incisions, the unexpected struck. A brutal Descemet's membrane detachment suddenly emerged from the paracentesis. We opted for the simplest approach first, placing an air bubble in the anterior chamber, hoping the membrane would naturally reattach. The next day, to our surprise, the patient was pleased with the initial outcome. But unfortunately, this relief was short-lived. A week passed, and the patient returned. Once again, Descemet's membrane was detached. Determined to improve the outcome, we decided to reattempt the procedure, this time using a longer-lasting gas, 20% SF6. 4 days later, despite our efforts, Descemet's membrane remained detached, much to our frustration. 3 days later, we tried again. This time we injected a larger amount of gas and closely monitored the patient's head position throughout the day. 1 week later, to our great relief, the membrane was still holding in place. 12 days later, the patient rushed back as an emergency. Descemet's membrane had once again detached. After careful discussion with the team, we decided on one last attempt. But then, in the middle of the night, a severe intraocular hypertension crisis struck. In an urgent nighttime intervention, we fought to stabilize the patient, successfully reversing the glaucomatous crisis. Descemet's membrane detachment is not a common complication, but when it occurs, it can have serious consequences after cataract surgery. If the detachment is small and peripheral, it usually does not cause significant issues. However, when it is extensive or close to the visual axis, it can lead to severe visual impairment. Several approaches have been used to reposition the membrane. Injecting an air bubble is a simple option, but it may not always be effective. Transfixing sutures offer another alternative, but come with technical challenges and a risk of corneal injury. The combination of air and viscoelastic can help, but it may increase intraocular pressure. On the other hand, using expandable gases, such as SF6 and C3F8, has proven to be a safer and more effective approach, with fewer complications compared to other methods. In more severe cases, a corneal transplant might be necessary. However, this is a more invasive procedure with a longer recovery time. The intracameral injection of SF6 or C3F8 gas has been shown to be an efficient and straightforward method. It can be performed under topical anesthesia and allows for a quick anatomical and functional recovery by repositioning Descemet's membrane, restoring corneal transparency, and improving visual acuity. Additionally, anterior segment optical coherence tomography, ASOCT, plays a crucial role in guiding this procedure. It helps map the detachment, identify the ideal site for paracentesis, and optimize the gas injection process, ultimately contributing to better surgical outcomes. Thus, the use of expandable gas stands out as a safe and effective option for treating Descemet's membrane detachment, ensuring faster visual recovery and reducing the need for more invasive interventions.